Welcome to Coffee with Coker, a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape. My name is Mark Reibold, and I'm the host of Coffee with Coker. I'm also a senior vice president at Coker. And in today's episode, we're joined by Roz Cordini, who's a senior vice president, and Jeannie Cagle, who's a senior manager. Both work within Coker's compliance department, where they are talking today about coding, and that's something both Roz and Jeannie specialize in. And specifically, we're talking about an effective approach to coding and compliance auditing and education. So this was I thought, a very good discussion that we had with both Roz and Jeannie, where we are talking about some of the changes that have come or are coming down the pipe on coding and other kind of related compliance matters, and then just some education tips, things to look out for, how the process works in terms of dealing with or addressing some of these changes and adapting for them going forward. So again, I thought it was a very productive conversation. We get a lot of questions related to things related to coding, I guess. And of course, Coker does a lot of work in the coding realm. So we thought it was a appropriate time to tee this up. And I know we'll be talking more about this in the future on both, Coffee with Coker episodes and some of the things, the material that Roz and Jeannie are working on. So we'll look forward to seeing that here in the near future. We always welcome feedback on our episodes. So if you have any questions, comments, suggestions as it relates to either this episode, any other episodes, or something you want us to cover on future episodes, please reach out to us. You can find us at coffeewithcoker.com. There you can also find all of the past episodes of Coffee with Coker. So please go to coffeewithcoker.com. Feel free to look and listen through some of our past episodes, and I hope you enjoy this conversation with Roz and Jeannie, and we'll look forward to talking with you all in future episodes. Thanks. Welcome back to the podcast, both two guests that we've had in the past, and glad to have them back. But we have Jeannie Cagle, who works in coding at Coker, and Roz Cordini, who is a senior vice president and really heads up all of Coker's compliance services as well as coding. Today, as we mentioned in the introduction, talking about effective approaches for coding and compliance, auditing, and education. Again, as we talked about, and we'll talk about more, this is something that we get a lot of questions and a lot of interest from different, whether it's hospitals or practices or health systems, whatever it may be. But Coker's worked in the coding and compliance realm for many years. And it's definitely something we do a lot of, and we're getting more and more interest from, because as things continue to change in the healthcare system, particularly the regulatory landscape and things coming out of Washington and government policies and legislation, there's always fluctuations and new things coming along as it relates to compliance and specifically within coding. And so there's a lot going on right now. We thought this would be a really good topic to touch on as we're going through some of these things. And so I'm really glad Roz and Jeannie are joining us here today. So ladies, welcome.
Thank you. Great to be here.
Well, let's jump right in, I guess. And by way of introduction to the topic, start with, and maybe Roz kick us off and Jeannie chime in. Let's talk about the importance of compliance. Obviously, it's something that's, it's a must-have if you're a healthcare provider organization, and it's always on the front burner in terms of things going on. So just talk about the importance of compliance, if you will, and the importance specifically for an effective compliance program.
Yeah, sure. Compliance and compliance effectiveness have been a concept that's been around for quite a long time, since the late 80s. And in fact, the federal sentencing guidelines first talked about really how an effective compliance program, if you are a healthcare organization who is undergoing some type of criminal sentencing for some type of bad behavior within your organization, but really talked about how if you have an effective compliance program, how you can get really credit for good behavior, for having that system in place. And over time, the Office of Inspector General has articulated the various elements of what makes up an effective compliance program for all sorts of physician practices and healthcare organizations, labs, home health, third-party billing companies, etc. And, whereas all the compliance used to be voluntary and is actually published as voluntary compliance, the Affordable Care Act, when it was implemented, made all of that guidance really mandatory for any provider who signs a participation agreement with Medicare. And so it really has become just the way we do business in healthcare, or the way we should do business in healthcare.
And, and I'd like to chime in too that probably the biggest difficulty that we see is most physicians, they just want to take care of sick people. So compliance, it feels like Big Brother kind of lording over and spying, the all-seeing eye watching you. But a really great, effective compliance program, the physicians see it as help and as support and as feeling confident they're following the rules and giving them, all the resources they need so that they don't worry about, getting in trouble. There's a lot of technicalities that go into it, but also creates a culture of helpfulness and doing things right.
Yeah, that's actually a really good point. I'm glad you said that, Jeannie, because I almost said in talking about compliance a necessary evil, and I purposefully don't want to refer to it as that because it doesn't have to be. I mean, it's something you got to do. And yes, to your point, it can oftentimes seem like a hassle or a burdensome, step that has to be taken, or it's something that's negative, right? Something that's non-compliant is naturally going to be poorly received, I guess. So I think sometimes we look at it that way, but it really could be or can be. And this goes back to the compliance program piece and why it's important. But having an effective compliance program really can be something that actually genuinely helps.
Right. Well, and it takes getting one uncomfortable letter from your local MAC aimed at a specific provider talking about how their billing practices look different than their peers, maybe in their state. Sometimes that is the first thing that gets the attention of a physician to say, okay, wait, maybe I do need to understand how I can do things differently. And quite frankly, I would say the most highly effective organizations and practices are those who actually view compliance as helping them do the right thing as opposed to being a barrier or a blockade.
Yeah. Yeah, that's a good point. And it's an important distinction. And I think that's a good segue or kind of intro into specifically talking about where coding fits in the whole compliance discussion. So when we do, as I say we, CwC is engaged, let's say for a coding review, have you all found that, there are any consistent patterns or anything, kind of trends to the findings there in terms of when we're typically going into those types of scenarios?
Well, I can give you, from my perspective as being, someone who does offsite audits and then, goes on site to do education for physicians, I'm usually directed by the compliance officer with a particular group. And I can tell you the top three things that we find when we come in from the outside that they don't realize typically are an issue. Number one is billing for nurse practitioners and physician assistants. It's confusing. It's convoluted. It's different in the hospital than it is in the office. It's different between Medicaid, Medicare, and all your commercial insurances. And so you can see why everyone's confused, but it often results in repayment. So that's first. Second is modifier usage, use of modifier 25, unbundling things that shouldn't be unbundled. And then the last thing is I see most often is just physicians who don't know how to assign levels of E&M visits. They're either using a code calculator that comes on the EMR, which usually winds up with codes that are too low. They think because of their specialty, everybody should be a level 5, and so they bill the highest. Mm-hmm. Or they follow what I call coding folklore, because somewhere somebody told them something, and that's what they use to assign codes. So it's very predictable that those are often the top three, I would say.
So in none of those scenarios did I hear you talk about anything being just flat out egregious. Is that typically the case that, these are, like you said, it's just kind of stuff they picked up or methods that they just kind of used and stuck to for however long, innocent mistakes, downcoding, upcoding, not to try to commit fraud or anything like that, but truly because there's just a lack of whatever it may be.
Right. Lack of education, understanding. And I will say is employed physician groups are getting bigger, and they bring on, let's say you take on a group of, 6 or 7 physicians in a particular specialty. It's hard to know what level of understanding they have, and then you pull them in under your umbrella. So it takes quite a while to know, how are they using their APPs? Have they ever had any coding education? So, there's a lot of moving parts.
Yeah, that's a good point too, Jeannie, because as we have been through this era of consolidation, many cases, these groups go through mergers and acquisitions, and they may or may not integrate. They may not do any sort of consistent, implementation of any sort of consistent standards. So you may have, a group of 100 physicians or 100 providers, but really it's made up of 5, 10 pods that were basically their own groups, and they're still doing things the same way. So you have, multiple different methodologies, even under one roof, if you will.
Another area that we see more and more issues with, and actually get asked to include this in some of the coding audits that we're asked to do, but it's looking at how providers' use of the electronic health record and how they've set up templates or how they use macros within their system, how that impacts the quantity and the quality of documentation in the record, and how that impacts the level code that's being selected.
Sure.
And there's an awful lot of guidance out there from the governmental payers, specifically around keeping watch on how you use those systems, because what you can end up with is over documentation in the record where, it looks like you've done a whole bunch of work. And so the coder then assigns a higher level code when in fact the provider may not have actually done that work, but because of, a dot phrase or something that they've instituted, it automatically populates the record.
Sure.
And so more and more we're being asked to look at how that impacts our level of code, because Medicare, for example, has said that that directly impacts medical necessity. And when you have that kind of over documentation, you can't meet medical necessity. And in fact, you may end up having what they determine to be fraudulent billing. So it's a real important area for providers to focus on.
Yeah. And that is a good point, Roz, because I think there sometimes is that assumption that, okay, we got this fancy system and it's supposed to solve all of our problems, right? And make everything easier on us. But of course, we all know the old cliche, garbage in, garbage out, but it's also about how well the system is set up and optimized for what you do and what you need to do. So like you said, there may be templates in there that are skewing data somewhere, or they're kind of framing it in a way that doesn't fully represent or isn't consistent with whatever standards may be out there.
I have a client now that's transitioning to a big EMR system. And what happens often is you have all these little silos of groups doing things that benefit them. So you have IT worrying about their world, and you've got the billing people being sure the claims are going out. But there's not an overall looking at, is this going to be a compliant note when it's all said and done? So to Roz's point, if you don't set that up correctly on the front end and continue to look at it, you can have a note or a template that's shooting you in the foot compliance. It's leaving something out that needs to be there that could be easily attained. It just never was set up right in the first place.
Mm-hmm.
Yeah, that's an excellent point, Jeannie. I was going to say, if anyone is just now implementing an EHR, take note and address that up front, like you said, because most organizations and practices got educated by the vendors or even their IT departments to say, look how cool this is. You can do X, Y, and Z. And in order for, adoption of these electronic health record systems, practices and organizations said, yeah, use these things. These are really cool. They'll help you. And like you said, with no oversight or kind of common pathway, you just kind of have the Wild West out there in terms of what ends up in the medical record.
Yeah, I think that's well said. And Roz, you alluded to this, and Jeannie, even you alluded to it earlier as well. I'm talking about, for instance, with modifiers. I have to think, well, let me ask you, with the changes that we've seen as far as coding, the codes themselves, coding practices and standards, billing practices and standards, and, especially on the E&M side. I mean, and as it looks like more and more is coming out, you get into bundles, you get into more modifiers and a new, CPT 10 or IDC 10. But you get into these things that have taken place, and then it seems like even more change is coming in the near future, or is likely. It seems like it's only getting more and more complex. Would you agree?
I sure would.
I definitely, yeah. And it's, it goes back to the compliance plan. Modifiers in particular can be tricky because the billing rules associated with those modifiers are pretty specific. And it really is helpful to include in your compliance plan a look at your, commonly used modifiers and incorporating a review of how, whether or not you're meeting the documentation requirements to support those modifiers as part of your compliance plan as well.
So let's go back a little bit to the coding process and kind of our approach when we're going into some of these, whether it's a coding audit or optimization or anything, education. But as we're kind of taking on these engagements where coding is something we're honing in on, what do you think are some helpful tips that, whether it's a hospital or a practice, a compliance officer or billing office, whatever it may be, some things they need to know? And I guess what are maybe some of the standard or common questions to ask, when you guys are going into these processes?
Well, I'll start off by saying I think one of the most important questions that we have to ask is, what is the purpose of this audit? Is it just a routine review? Or, do you have concerns? Are we being engaged through counsel to invoke the attorney-client privilege and protect the results of the audit? Or should we be? And sometimes that's the conversation we have is, based upon the purpose of the audit, it may be in the client's best interest to engage us through counsel to protect that as much as possible.
And, oftentimes when we start out on a project, I'll just ask, whoever the project manager, if it's the compliance officer or the billing director or whoever, when we are finished and we leave, what would make you say that's what we were looking for? What is the takeaway that you want from us? Yeah, Roz is right. Why are we doing this particular audit? And it's way more than just looking at a note and giving results, because there's a lot of culture within a place as far as, how you communicate information, how they use their APP. So asking all those questions on the front end are very important. You need to know if their compliance plan spells out what set of guidelines, 95 or 97. Have they made a designation for that? You need to know their Medicare carrier, because they even have more specific guidelines for their particular states, where they're the MAC, than just general CMS guidelines. And one of my most important questions I ask is, do you have an in-house audit team or coding team, or who do you use? Who assigns these codes? Because the last thing we want to do is appear to be, the government showing up in black suits. I want that in-house audit team to be like, yay, our cheerleaders are here. We've got folks who can help us do this right. And then for the physicians to have the same feeling, they're glad we're there, that we're there to be helpful. And in the coding team's defense, sometimes they've been working on a problem and they can't seem to get much traction. But we always say, hey, if we come in from out of town with a suit on and we're carrying a briefcase, they'll listen to us. So maybe we can, help make a point that you guys have been struggling to get across. So We very much want it to be a team effort, and that we make their in-house coding team look good. You know, we're not coming in to make their job harder. We're coming in to be support.
Yeah, it doesn't have to be like the IRS and you know, like you said, black suits showing up and looking over people's shoulder. That's not the intent.
No.
And I got to think, and this probably goes back, Roz, your points, but what systems are using? I would assume are an important piece there too, because if you're going in there and you're not just audit, like you said, Jeannie, not looking at notes, but, you know, truly looking at a process, the team, the people involved, as well as, you know, where's this data going? How is it being used and reported on and tracked and all of that stuff? And that's where we go back to, okay, now let's try to diagnose. Maybe there is an issue, but it's not the coders doing anything. It's not the providers doing anything. Maybe it's something in the system.
Sure. Might be in the system, might be in how the system is set up. It might be, you know, for example, some systems will log who the rendering provider is and then have a separate field for who the billing provider is. And sometimes in the electronic world, those systems can have quirks and problems, and you may end up billing out under a particular provider's NPI that's inappropriate based upon a service that was actually provided. And so sometimes we can pick up on some of those issues when we're in the records auditing as well and get those corrected.
Yeah, good point. We talked earlier or briefly about the system and the requirements as it relates to coding continuing to get more and more complex. And I think we're seeing that in action literally today. We're recording this in January of 2019. And so maybe speak to, if you can briefly, some of the changes that are coming down the pipe. I know we had the Medicare physician fee schedule final rule come out and starts as of 2019, as far as I'm aware. And, you know, any other changes in addition to that, maybe speak to that for some of the things that we can expect maybe here just right now in 2019.
Either one of us could probably jump in on that. But, you know, the whole concept behind the E&M changes in the final rule was to purportedly decrease the burden, the documentation burden that's on providers. Because currently, whether you're using the 95 or 97 guidelines, there's specific, you know, tick marks you have to make in order to get credit or to be able to assign a particular level to do certain things. And quite frankly, I'm actually going to go to 2021 first, and we can kind of back into 19, but some of the changes they're recommending or that are in the final rule to go into effect in 2021, to me, are so problematic on a number of levels. But one of them is because they're going to allow the provider to have a choice on how they're going to document. They can document in accordance with the current 95 or 97 guidelines. They can do it based on time. They can do it based upon medical decision making. And that's all fine and dandy. But when you step back and you think about, you know, a practice with, you know, 10 providers or a hospital system that employs, you know, 300 providers, and you start thinking about giving folks the choice on how they're going to document. Can you imagine Jeannie going in, doing an audit and not having a handle on whose record you're auditing and what choice they've made? And so from just the standpoint of planning for, you know, practices and health systems, you know, whether or not that gets changed in subsequent rulemaking, which I somewhat think will, but organizations and practices really today need to start thinking about what's this going to look like for us? And are we going to set a single standard across our practice or our employed group on what we're going to expect from documentation? And certainly that's exactly what should be happening starting today, looking toward the future, because, and Jeannie can speak to this, even with the 2019 changes, there's still a lot of unanswered questions. And yet, you know, that time period has already started.
Yeah. You know, actually, to Roz's point, this is perhaps a little practice session in 2019 for if these changes do come in 2021, because decisions need to be made. Each group needs to make some decisions, or should have already. They need to put a policy in place, and then they need to start to implement it. For example, in order to relax the rules, now they don't have to re-document all the information from a previous visit that they used to have to redocument. Every note stood alone. You could not refer to old information. The staff could not document the HPI. Well, now they can, but you have to indicate it's been reviewed. So in my opinion, and what I'm seeing our employed physician group clients do now, is they're writing policies, they're putting them in place, and they're communicating it with their providers. Because all of your physicians and APPs have been reading about all of this in their, specialty newsletters and such. And so everybody's wondering, so what does this mean exactly?
Mm-hmm.
And you have to make adjustments within your EMR to accommodate it. So the ability to put a phrase in that says, I have reviewed the information needs to be there. So there's a lot of moving parts to this. What I see happen often, though, is, and even now I have one group that's somewhat paralyzed because they haven't gotten their committees together to discuss it so that they can have their 14 meetings. And in the meantime, everybody's just documenting, all over the place. So sooner rather than later, a decision has to be made about, these new guidelines that went into effect on January 1st.
Yeah, I mean, it seems overwhelming, honestly. If I were having to think about all those things, Jeannie, that you just mentioned and listed, and I'm sure there's, like you said, there's 20 other things that are kind of either steps that have to be taken to address those other items, or we don't even know what they are yet because we hadn't gotten into it, or they're unique to different organizations and different cultures, to your earlier point.
Right.
So
and one other point too is these are Medicare guidelines. Well, Medicare is not the only payer that you respond to. So you still got Blue Cross Blue Shield and Aetna and United and everybody else, and they all very well may have their own
good
take
point
on this.
Yeah.
Well, and there's no certainty whether or not the other payers are going to jump on board with these changes that are supposed to go into effect in 2021. So there's a whole lot of work that needs to be done by all sorts of different groups in order for that to really fly in 2021. But, to Jeannie's point on the EMR, it's not probably good enough to just say, I reviewed something without indicating the date of the note you're referring to. And that's a question that's come up because, if you like the note that was written 2 visits ago, but you merely, have a drop-down box now that says, I reviewed, the information from the H&P and agree it's current and accurate, it's, I think logically going to fall to the immediate prior note. And if that's not what you intend, the systems have to be set up in a way to capture the actual date of the visit that you're intending to confirm.
Do you feel like, what is your opinion that, do organizations have a handle on this? Are they able to digest all of the information, all of the policies and rules, and then go and actually, incorporate them into a plan? Or, because, this is an area where there's very low margin of error. I mean, there's not a lot of wiggle room here. The cost of not getting this right can be great. And again, usually it's not the egregious fraud that is the issue, or the biggest issue. But it's, just a lot of maybe small things. Do you feel like they're able to adequately address these and get a handle on all this stuff, or are we kind of behind the mark there?
I can tell you that the coding teams and the people in compliance are very aware of this. The difficulty is in a big system is getting the IT experts to get in line and make their kinds of adjustments because they've got other fires to put out. It's educating a huge group of providers, including staff, on what the new rules are. There's a whole lot to do. I think everyone's aware of it. It's just working out the process. How
do we put it into an actionable plan and work stream?
Well, and one thing I don't want to not touch on, because it's such an important part of all of this, whether we're talking about the new E&M rules or just auditing in general, but it's the education that comes immediately behind those audits to discuss with the providers, what are the findings, where are the things that we see you can improve, Where are the things that we think you need to be aware of because they're not quite in line? And that's where I think that reinforcement and re-education about these new rules can come into play too. But Jeannie, why don't you speak about the education process that you engage in with the audit?
So let me just say, in my experience, you cannot do ongoing audits and email results to providers and expect any change whatsoever, because you've got to have the face-to-face discussion or, video conference, or somehow have a conversation to focus specifically on that provider, what they understand, and have them leaving feeling like they've been given some tools in their toolbox to make a better decision about their coding. So I just feel like if you want to make the best use of any kind of audit, then you've got to follow up with education. 8 times out of 10, providers will say, "This was very helpful. When are you coming back?" So that's what you want to create a culture within any physician group or provider group. It's where they see the people coming in to talk about compliance and coding and those sorts of things as a resource, and it's help. So, and you know what? That's a culture. That is it is not a sprint. It is a marathon of just creating that environment of helpfulness and resource.
Well, it also goes back to your point too about, that this can be a burdensome thing. It can be a negative thing, or this can be used as a tool to be, to create value and be positive. And I think, it's one thing to assess, right? There's a lot of analyses we can conduct and perform, but it's a whole other thing to take an assessment and translate that into an action plan or some sort of some work stream that then whatever needs to happen, whether it's changes, whether it's different things, new things, whatever the action needs to be, that's something there's a plan for how they're going to do that, and ultimately translate that into value, right? What's the reason for doing it? Back to your original point, what are we trying to accomplish here? Just not getting dinged by regulators is just the low bar. I think this being said, there's a lot more we can do.
Exactly.
Well, that's helpful. And this has been extremely, I think, helpful discussion, talking about something that I think there's a lot of uncertainty around, and isn't always the sexiest of topics necessarily, talking about compliance, but it's something that every single healthcare provider organization out there absolutely has to deal with on a daily basis. And, there are ways to truly benefit, for this to truly be a value oriented activity as opposed to a necessary evil. So I think that's why, in my mind, this is not only relevant, but extremely helpful. So I appreciate that. Just one last thing as we close out and bring it full circle, kind of going back to our process and some of the work we do as far as coding, audits, and education and compliance programs in general. Just maybe speak briefly to the kind of deliverables and outcomes and approaches even around when we're working with a client as it relates to coding and documentation compliance. Maybe just briefly walk us through kind of what that process generally looks like, and particularly, what they're getting out of it.
Well, I can tell you our typical approach is usually it's a group that wants an outside look at how they're doing their coding and billing, and they want some education for their providers. And so all those things we listed earlier, we asked those questions. Now we're able to, goodness, it's been a long time since I haven't been able to log in remotely into an electronic medical record and do that off-site before we come on-site. Usually look at a sample of 10 to 15 notes. It's not a statistically significant sample. That would be a whole lot more. But we're really looking at it from an educational standpoint. I call it name that tune. I can pretty much tell what a doc's habits are within about 10 to 15 notes, because we're all creatures of habit. So we do the audit remotely. We look at the E&M codes. We look at their ICD-10 codes. And we also look at any ancillary services that were billed on the same day. That's where you would catch modifiers and that sort of thing, and if they've been used appropriately. And then we create a one-page report card is what we call it, and it's in user-friendly terms. It's in, the claims are all listed. It's in black if it was correct, if we feel like we could defend it. It's in green if the provider could have billed a higher number and perhaps gotten some more money. It's in red if something's missing. And so we try to customize the conversation with the physician based on their results. So if I have a provider that's got multiple colors on their report card, that tells me that they're kind of all over the place and they're probably doing a lot of guessing. If there's a lot of red, then we're going to have a very different conversation than the provider who has a lot of green. They're probably just trying to stay out of trouble and they're just putting lower codes. And so we're customizing that conversation. One other thing we do is a bell curve analysis. So you can kind of take a high-level look and just see, is this provider an outlier in their billing pattern? And docs really like to see that, that they're compared to their own specialty, and they find that to be helpful too. So I usually tell a doc, if this bell curve and this report card give us the same message, then we can pretty much count on it being legitimate. And so let's talk about what we found.
And I think that's helpful because, again, like you said, you're using their actual data, and then you're able to pinpoint, okay, here's issues or no issues. If there are issues, here's where we can kind of drill down and then translate that over to the education piece and the action plan to say, and here's how we can correct that. Here are some solutions, not just here's a report card, see you later type thing.
Oh, yes. And we love to do the sandwich method, right? Everybody's doing something good, even if they're all red. I believe they care about their patients. So I start with that,
Right.
But give them the tools to do better.
That's right. Well, I think it's also, it's interesting. And I mentioned this in the intro, but both of you ladies being RNs, and then Roz, you also having the perspective of an attorney who's been, legal counsel in a hospital organization, those different perspectives, I have to think, are extremely beneficial because when you are trying to get that full picture to understand, okay, what is going on here? And okay, now what can we do to improve or change or optimize, however you want to put it.
Well, that's right. And I'll restate what Jeannie said earlier. We are definitely, we come in with the perspective that we are all on the same team. And that we know that providers really want to do a good job and are not, out there aiming to do bad things or things that could be indicative of fraud and abuse. And so we come in with the perspective of, we're part of the team. We want to help you be higher performers and do things in a really good way. And usually that approach is appreciated by, really our colleagues in the healthcare field.
Sure. Absolutely. Well, ladies, I guess we will wrap it up there. I greatly appreciate your contributions. I think this is again has been a very helpful discussion, and I know we're going to have follow-up conversations and other materials coming out from us on these topics. So, just want everybody to keep their eyes out for that, and forward to talking with you all in future episodes. So, thank you.
Thank you, Mark. Thanks for inviting us.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We'd love to hear them and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter @Coker Group, And then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.